Welcome everybody. Apologies for being a little bit late to start. If you wouldn't mind just bearing with us, we're just getting Paul's slides uploaded, ready to share with you all. And perhaps while that's happening, I'm just going to run through a few things with everybody. I know that more people will be joining, so welcome as you're joining us. So my name's Liz Darlison. I'm the Chief Executive of Mesothelioma UK, and I'm also a consultant nurse at the University Hospitals of Leicester, and I'm your chair for this afternoon's webinar. This is our 9th webinar, and I'm pretty sure this is one of those things that's going to continue even as we get back to some post-pandemic normality. It's been so successful and it's been such a great way to connect with people. I'm pretty sure we are going to continue. So a couple of Meso UK updates that I'd like to share with you first of all. Events coming up on the 1st of October, which is only 5 weeks away now. We have the Mesothelioma UK Patient and Carer event taking place completely virtually again this year. We're still not out of this pandemic, and we are a little bit loath to bring people together while you know, the transmission rate is so high. Although we seem to be coping much better with this third wave, we certainly just don't want to over encourage people to be mixing. So it's going to be completely virtual, and there's more information on the Meso UK website about our Patient and Carer Day, or you can always give us a call and we'll chat to you about it over the phone. The fundraising team have asked me just to discuss with everybody the latest fundraising opportunities. We've joined with 20 other charities in the same way that we did last year, and we've created the 2020 challenge. So the idea is, it's quite simple. You choose a challenge you would like to do for 20 days. You print off the challenge tracker and complete it in your own time between the 20th of September and the 20th of December. And whether you're 4 or 94, there is a 20-day challenge out there for you. And we've had all sorts of things that people have done to raise funds under the 2020 challenge. And I think the details of last year's event is still on there if you want to get a bit of inspiration. You can run, cycle, you can bake cakes for 20 days. It's up to you really. And you can do it 20 days in a row or 3 a week, or you can do 2 days in 1 week for 10 days or whatever. It's entirely up to you. I also just want to tell you a little bit about our volunteer programme that is soon to launch. So we've had volunteers at Meso UK in the past, quite ad hoc, just people who came forward and wanted to support us at the main office in Leicester. But we've now taken that a step further, and we're asking people who would like to volunteer in the Newcastle or Leeds area initially. And we've got our first volunteer drop-in session on the 10th of September in Newcastle, and the second one the day afterwards in Leeds. And what we're trying to do is just encourage people to come forward and be kind of advocates for the charity within your regions. So it doesn't matter how much time you've got to spare. If you think you might like to volunteer for the charity within your locality, then think about coming to one of our drop-in centres. So September the 10th in Newcastle, and then September the 11th is in Leeds. So I'm just going to look for a thumbs up from Paul. Are we good to go with your slides, Paul? Yeah, we're good to go. Okay, I just would like to ask everybody, if you wouldn't mind remaining muted, please remain muted. And if I can ask you all to switch your cameras off, then please do. We'll leave just Paul's camera on throughout the presentation. We are recording this, so it will go out live on our YouTube channel. And if you have any questions, please, if you wouldn't mind typing them in the chat, or you can email Meso UK and they will be sent through to me as well. And then at the end, I'll pose your questions to Professor Baas on your behalf. So type your questions in the chat. Other than that, then please email them to Meso UK and they'll also be messaged to me so that I can ask them on your behalf. So without further ado, it's a huge pleasure to introduce Professor Baas, who gained his medical degree in 1986 at the University of Amsterdam and trained as a chest physician at the Free Hospital. Currently, he's Chief of Department of Thoracic Oncology at the Netherlands Cancer Institute in Amsterdam. He has a PhD in Applied Medicine awarded by the University of Amsterdam and is Professor of Thoracic Oncology at the University of Leiden. He's published over 250 peer-reviewed papers, and he's involved in several cancer research groups such as ETOP, the European Thoracic Oncology Platform, that is, the EORTC and ESMO. Since 1992, he has focused on the introduction of new treatment applications and studies in patients with lung cancer and mesothelioma. And I'm delighted we're going to be hearing about a new kind of treatment opportunity, hopefully coming our way in a clinical trials in the future. But Professor Baas, welcome, and thank you for talking to us about combination immunotherapy in mesothelioma.
Okay, Liz, thank you very much for the very kind introduction. I think it's great what you all do. Meso matters already for me since 1992. I've always been very involved in this subject. So I'm going to give you an overview of mesothelioma, especially the treatment with immuno-oncology. So I'm going to share my slides here. I hope you can all see them. Oh, one moment. Yeah. Is this okay? You have visual? I see no.
Yeah, I have visual. Thank you.
Yeah,
perfect. Okay. So it mostly comes down to asbestos. Although there is a small percentage of patients who have contracted the disease without having ever seen an asbestos or knowingly seen an asbestos fiber. So these are my disclosures. I'm involved with some companies, and one of the important ones here is Bristol Myers Squibb, because they support me in also some kind of research, and I've been one of the first author of one of the great papers that has come out this year. I will come to that. So I first would like to start with a general introduction and what we achieved until 2020. Now, what is the current status of immunotherapy and what we can expect for the near future? So I hope I will have your attention for some time. Now, it's important for me to tell you that mesothelioma has been considered by the World Health Organization to be a rare tumor, but it's not so rare. And we all know that asbestos has been very, very good for isolation and being used in shipyards and all kinds of construction buildings. And we have noticed that it takes about 40 years sometimes to develop a pleural mesothelioma if you have had your asbestos exposure. And for the Western world, we have all kinds of regulations that you are not allowed to work with it anymore, or you must have special precautions. But it's not that simple, because in Russia and China, there is still a lot of asbestos being produced, and this is all transported also to developing countries, and there's hardly any protection at all. So I think we will be still stuck with mesothelioma for quite a long time. And I'm not even discussing the fact that people could also develop lung cancer when they're smoking, and that is augmented by the use of asbestos. Now, there are some diagnostic pitfalls. It's not always easy to make a good diagnosis, also because many of the people who have worked with asbestos and present with pleural effusion or a thickening, they have comorbidity and they're somewhat older. So that is something we have to keep in mind. The incidence may be higher than we expect. And of course, when we first started the treatment of mesothelioma, we had to learn a lot, and also to find out that many drugs did not really work as we planned. Now, this is just an example of how a patient with a pleural mesothelioma can present. Here you see a CT scan on the left side. It's a transverse cut of the chest, and the coronal, the anterior view is on the right side. So what you can see is that left is right and right is left, but if we look to the right side, you see that in the left lung, in this case, there is a rind. I hope you can see my mouse, my arrow, that this is a rind of the tumor, which is adjacent to the ribs and here to the vascular structures. And there are also some lymph nodes. So you can have some crowding of the ribs, and you can have a dysfunction of your left lung. On this side, the anterior view, you see that the diaphragm with the spleen and the stomach has been lifted upwards, so the lung is not functioning. So patients present with shortness of breath. They can have a coughing without any mucus production, and of course they can have pain. So this is in general the radiology that we see, sometimes with a lot of fluid, which has to be taken out before you can initially see what is happening. Now, what was on the menu for our patients until or since 2004? That was platinum plus pemetrexed, and I guess that most of you, the people who joined this symposium, have heard of it or have even had treatment with it. So, first-line therapy. What are the ESMO guidelines? And this is a peak view for the very near future, because we are working on the last checkups of the ESMO guidelines. The last one, the previous one was 2015, and now the guidance of Professor Popat from London, we have stated that patients in a good performance status can be treated with a combination of platinum, and that can be cisplatin or carboplatin, and pemetrexed plus vitamins. And you give this for 4 to 6 cycles. You can also combine it with bevacizumab. There is a level of evidence and a recommendation. Level of evidence 1 means it's highly significant, and the A is it's highly recommended. However, bevacizumab is not being registered in most countries, so you will hardly see that in this combination. Second-line therapy, we have a lot of options, but there is not one that really is accepted at this moment. And then we're going for IO therapy. So what was the data in 2003, 2004? That is this survival curve, where you see the percentage of patients, this is 100%, this is 0%, who join the treatment with the pemetrexed or Alimta cisplatin versus cisplatin alone. And then it's clear that the overall survival here for the combination is better than for cisplatin alone. But at the end, at 20 to 24 months, the curves come together. So chemotherapy alone is not going to deal with the problem alone. You really need something more. And let's keep in mind that 20% of the patients who had only chemotherapy had survived after 2 years. That's important for later. Now, I was talking about the bevacizumab, and that's a drug that inhibits the growth of vessels. And we all know that if you have a tumor and the tumor wants to grow above 2 millimeters, it needs a vasculature, some kind of vasculature. And then it has nutrients and oxygen so it can grow. But if you give a drug like bevacizumab by infusion, you will inhibit this growth. So there is a starvation of some parts of the tumor. And here these curves also showed, and when we're only going to look at the right-hand curve, that the black one with chemotherapy plus bevacizumab is above the gray one. And it's doing better than the study we just saw. However, you can understand that the difference is not so big. It's just over 2.5 months. So we need something which is more attractive to give. So from 2016, the menu had changed first-line therapy, platinum plus pemetrexed, or when you're in France or in some other countries, Switzerland, you could add bevacizumab. And this is still very, very small when we compare it to everything we can give, for instance, for lung cancer. It's a different disease. And then I'm going to talk about the history of immune oncology trials. And this is just a timeline in blue on the top. And then it's a bit complicated slide, but I will walk you through it. Here we have the phase 1b and 2 studies. And these are the simple studies with a few patients or just one arm. So not a randomized study that one person gets this drug and the other gets another. So these are quite often the simple ones. And the phase 3 studies are below here. These are where you randomize patients. So one will get the standard of care and the other one will get immunotherapy or some other drugs. And the yellow boxes mean that there were studies that only had one drug, like pembrolizumab, avelumab, tremelimumab, or nivolumab. So a lot of difficult names that you really have to work on quite often to pronounce it correctly. Now, you could also have combinations, and that's the green boxes, where we had a combination, MAPS2, of ipilimumab plus nivolumab, like this one, and also here another one. Finally, the DREAM study was a combination with chemotherapy, and I think this is something we must keep in mind for the future. I will talk about the phase 3 studies also, PROMISE-meso and Checkmate, because they will give you an insight in how the immune therapy is taking place in mesothelioma. And now there is a lot of more attention being given on these phase 3 studies. We have combinations pembrolizumab with chemo, or even 4 drugs, atezolizumab, bevacizumab, carbo, and pemetrexed, or durvalumab. So there's now a lot to choose about. And I think this is only of great benefit for the patients who have to be treated. Now, how do you start with immune therapy or a new kind of therapy when you have mesothelioma? You first have to look in the second line treatment. So that is a group of patients who have been treated with the standard of care, but the disease recurs, and you must try to find something that will do better. Now, when I started in 1990 in the EORTC, it was clear that we were only testing chemotherapy drugs, single agents, so only one drug was tested, and in nearly all of them, we had hardly any response, and this was quite frustrating. But for the immune drugs, it seems to be different. Now, there's also an ESMO guideline, but there's also the NCCN guidelines, and that's a guideline from the National Comprehensive Cancer Network in the United States. And here they are already in 2017, they have a recommendation for first line and for the second or third line. And here they already had drugs like pembrolizumab or nivolumab plus ipilimumab. The risk here is this is all based on very early studies. So it is not as strict as we from the ESMO had made our recommendation, but it's already there. So the people in the States were already giving an idea, this is going to be important. So let's focus on that. And here you see in the box all the studies that have been performed in second line with the combinations. And I'm not going to go through them all because that is taking far too much time, but there are a few that are of interest, and I will focus on them now. First, you have to prove that a drug that you're going to test is doing better than best supportive care. And this was a study that has been presented by Professor Dean Fennell from Leicester. He's a very active person in mesothelioma. I've worked with him for many, many years, and it's always fun. He's sometimes difficult to get on the phone, but if it works, it's okay. So he started, together with all the colleagues in the UK, a phase 3 study looking at the efficacy of patients in second line who were treated with nivolumab or placebo. So you can see that there were 332 patients joined the study. They had to have a mesothelioma in a good condition, and they had to have progression on the CT scan and at least one line of therapy. And then they were randomized to receive nivolumab every 2 weeks by infusion or an infusion with saline, so fake drug, placebo. And this was given for up to 12 months. Now, this is a very important study, and they decided that the randomization was 2 to 1. So 2 patients would go into the nivolumab arm and 1 into the placebo, because it's very difficult, as you can understand, if you're a patient and you're in a lottery and you have to draw a straw, and maybe it's the shortest one, and you don't really want that. If it's new, you would like to have a chance of it, but it's the basics. And in medicine, we sometimes need these kind of studies to really know what we're doing. Now, luckily, if my slide progress, yeah. So here you see 2 curves. One is the progression-free survival, and one is the overall survival. And the progression-free survival is, of course, all the patients starts without progression, and in time, in months, you will see the progression, how it works. And here is the progression if a patient would die. So the disease will be quicker in recurrence than the patients would die of the disease. And the difference between the 2 curves on progression-free survival and overall survival is much larger than we saw before. So you know that nivolumab is doing something good for the patient. In Japan, they had one study, the MERIT study, and the MERIT study showed that if you gave nivolumab, you could have a response rate of 30%, so tumor would shrink in 3 out of 10 patients, and the disease control rate, so there is no growth after 12 weeks, was in 70%. And these are percentages that we see coming back all the time. So you're doing pretty good with it. So you can control the tumor. Sometimes it gets smaller and sometimes it stays the same. This was for the Japanese government already the reason to accept it as a treatment, as a registered treatment in Japan. Oops. Now, you also have something else, because nivolumab is a so-called checkpoint inhibitor looking at PD-L1. And tremelimumab is a drug, a CTLA-4 inhibitor, that works more closely in the lymph nodes, and it recruits the T cells, the killer cells, to be active and then sends them to the tumor. So pembrolizumab and nivolumab, for instance, they work at the tumor site, and the tremelimumab and ipilimumab, they work in the lymph nodes. So they tried this company, tremelimumab, in a phase 2-3 setting, but you can see the curves are almost the same. It was really not a benefit. So this was a negative study. So you must be very sure what kind of treatment are you going to give to your patients. Then, if you have shown that pembrolizumab or nivolumab is working compared to best supportive care, doing supportive care only, then you should compare it to chemotherapy. And here, the study, which was run by Professor Popat, randomized patients to Nivolumab every 3 weeks, also targeting the tumor cells and the T cells, versus gemcitabine or vinorelbine. And these were drugs that are used, not registered, but they are used. And then the treatment could be given for up to 2 years. Now, one of the good things of this study was that if you were randomized to receive only chemotherapy and it didn't work, you could cross over to the immune therapy. So you would not lose maybe a little group, but most would all have the chance to go over and have immune therapy. The primary endpoint was progression-free survival. So when does the tumor grow again? Because overall survival is very difficult to use when you have chemotherapy followed by immune therapy, or you compare it to immune therapy followed by chemotherapy. That would make it a little bit blurry. And then the outcome came. Primary endpoint, progression-free survival. And here it's even worse than with tremelimumab. The curves are superimposable. They're just on top of each other. So here it did not matter if you gave chemotherapy or immunotherapy, but there was something more. It was not the whole story. You can also see that for the immune therapy, 22 out of 100 patients had a response. These are the green bars. That means that 22 patients of the 100 would see the tumor become much smaller, more than 30% reduction, while chemotherapy was doing not as good as that, and only 6%. So there is a benefit. And you must also consider, of course, toxicity. How well is it taken by the patient? Is it a lot of side effects? Can you do your normal work? Yes or no? So there's still a reason why you should give immunotherapy. But these figures are very clear. You cannot do it for the progression-free survival. Now, in my institution, we felt that we would like to learn a little bit more about what is happening in the tumor. And you can understand that tumor tissue is not easily to be obtained when you have a chest cavity and you can't open it. You can't put a zipper in it and take biopsies out of it. So we designed a study where we took biopsies before we would start with treatment. And after 6 weeks, we would also take these biopsies again from several spots in the cavity by looking through a VETS thoracoscopy, and then see also what is the effect of nivolumab plus ipilimumab. And here we came also to a disease control of 68%, and 30% had a partial response, but there were no complete responders. So there was always some tumor left behind. Of course, you have to consider, does it give adverse events? Is there a lot of toxicity? And that was quite easily managed. We only had 35% of grade 3 toxicity, meaning that you would have to do something to the patient, give antibiotics or other drugs, or sometimes maybe even admit to the hospital. But the most of the patients could have the treatment without big problems. Now I would like to share a slide. This is a case. This is a patient of mine. He's 56 years old. In December 2015, he was showing shortness of breath, went to the GP, who sent him for radiology. And there was a pleural effusion on the right side. You know, left is right. And there was a thoracoscopy done where biopsies were taken. I will show you a picture of that from here, from the dorsal side of the chest cavity. The fluid was taken out. It was an early stage, because T1 means early stage, not too much tumor. And then we installed talc to prevent the fluid to return. And of course, in 2015, that was on our menu. We only had a platinum pemetrexed, and it led to a stabilization of the disease. Now, unfortunately, a year later, the disease recurred, and now it was T2. There was a bit of fluid had recurred, so pleurodesis does not always work. And then he joined in the study that I just described, getting ipilimumab plus nivolumab. So we're trying to recruit the T cells and learn them how to recognize the tumor with the last drug. So here you see a picture of what we see when we look into the chest cavity. And here you see a rib from the inside, here another. And then you see the lung here with some anthracosis that is due to air pollution, some carbon particles, and there's an adhesion. And this is the chest wall for the rest. You see the deep, and there are some little lumps here and here too. And these are the mesothelioma. Now this is an early stage, so we took biopsies at the beginning, and after 6 weeks, we took other biopsies and to look what is happening in the tumor. Is there indeed more T cells, or are there macrophages which can inhibit the T cells, or is nothing happening at all? So can we identify patients upfront who are candidates for the immune therapy? Because if you're going to give it for 2 years, that's quite a long time. So 2017, we started. There was a little bit pleural fluid. September 2019, 2 years later, 2.5 years later, you see no tumor. So the treatment was very successful, but there were also some side effects. He had some toxicity. He said, well, it takes a lot of energy. Fatigue was moderate, but he could do his daily life without any problems, but not running up the stairs or going for long hikes. He said during the infusion, he had some rigors and some temperature rise. And after just more than a year, he had complaints of colitis. And colitis is, of course, something that we are always aware of, that this is a side effect that if you have ulcerative colitis and you give immune therapy, that can really become a problem. Then patients could have such a high frequency of diarrhea that they might even succumb to it. So in this case, he had moderate, that's grade 3, diarrhea up to 5 times a day. Was a colonoscopy done. So you see here the large bowel. It's a little bit red. It's a little bit inflamed. And they said, well, it's not a severe colitis, so we only give him a little bit of prednisone, 30 milligrams. That's not so high. Normally you have to go 1 milligram per kilogram, very high, to avoid that the inflammation in the colon will be more and more. And he told me that there was also psychological burden. You still have to go to the hospital. It will take a lot of energy from you. Let's see. Yes. At the same time, there was a French group who were doing the same study, but they modified it a little bit. They did the same study that I performed with my colleagues in my institution, but they said, no, let's also compare it to nivolumab alone and see what is happening if you give this for 2 years. And France, of course, is much larger than the Netherlands. We only have 17 million inhabitants, and luckily not too many have mesothelioma. But in France, they could have quite a number of patients who could be entered, 125, while our study only had 36 patients within a year. Their outcome, the survival, is shown here. That if you give nivolumab and ipilimumab, you have this kind of survival figures. of a progression-free survival. So the tumor stays away for quite a long time, and it's better than nivolumab alone. The overall survival was better, 16 months versus 12 months with nivolumab. So there's a gain to have the two regimens, the two drugs together. And this is the basis for the most important paper, which I would like to discuss today, that we went to the first-line treatment. So we said we have enough data to be sure that we're not harming patients, but we are also now able to give them the combination of nivolumab and ipilimumab maybe instead of chemotherapy. So this is a randomized study. And in first line, and it has been published in January 30th in The Lancet. Multi-center, 30 centers in something like 15 countries joined. Now, patients had to be in a good condition, no prior treatment, and what the Americans always wanted to say, it must be unresectable. Well, in the our Western world, in Europe and the UK, we feel that there's only a very small special group that are considered resectable. So you have to watch out for them, but the majority of the patients will have irresectable disease. You cannot take it out completely. And here in this study, 605 patients were randomized to receive nivolumab plus ipilimumab, 303, or in 302 patients, carboplatin or cisplatin with pemetrexed. So this is the standard of care. Patients could have this arm, the immuno, for up to 2 years, but the chemotherapy only 6 arms. It was, however, allowed for the group of patients who failed this regimen to receive second-line therapy, but they could have everything except for nivolumab plus ipilimumab, because the primary endpoint is overall survival. And as I discussed before, if you're going to give everybody here also the immune therapy, then you cannot really rely on the outcome of your primary endpoint. Now, we looked at a lot of things, but the primary endpoint was for all the patients who came. They were randomized, and you can see here that at 24 months survival, you don't have 20% of patients surviving, but 41. So it's a huge difference to what we had in the time that our first study with chemotherapy was presented. For chemotherapy alone, it was 27% here, but for the combination arm, 41. 18.1 months median overall survival versus 14.1 months in the chemotherapy arm. And this was significantly better for the chemo. Now, all these dots here and all the little stripes here, what do they mean? They mean that at the time that the study was analyzed, these patients were still on treatment or had finished treatment, but were also still alive. So we had quite some patients who were censored. And this might lead to one of the things we are now going to look at in the near future is who is going to be the real long survivor. Because for melanoma, the skin tumor, and for lung cancer, we know that immunotherapy will not cure them all, but there will be a group who will survive for more than 3 to 5 years. And this is very promising because this is something we have not seen happening in many of these tumors. So the long-term effect might be so that 30% might survive for 5 or even longer, 5 years or longer. So this is something we are looking for in the near future. Now, there was also something happening in this study, and maybe a bit difficult to explain, but you have in general 2 types of histology: epithelioid, that's what we see most in mesothelioma, and non-epithelioid. And we know that the non-epithelioid is more aggressive. And although it's about 20-25% of the cases, it will, chemotherapy does not work so well. And here it is clear that the red line, the combination therapy, is doing extremely well compared to the chemotherapy. So in 2 years, 8% of the patients who received chemotherapy were alive versus 38 with combination treatment. Now that's a real difference. So I think one of the first conclusions, we call it indeed a no-brainer, is if you have a non-epithelioid one, like sarcomatoid or biphasic, this makes a difference. Now, if we look at epithelioid, it means that the difference is smaller. There's still a gap. It's a gap from 16.5 to 18.7 months. That's 2.2 months, but it's not as expressive as the non-epithelioid. But in both cases, the immunotherapy outperforms chemotherapy. And it's always nice to keep something in the back pocket from might the tumor recur. Then you could give first the less toxic, more effective treatment, and later on the chemotherapy. There was also something else, and maybe a few of you have heard of PD-L1 expression. Now, PD-L1 is on the cell surface. It's a sort of a protein. It's something that makes the tumor cell invisible for the immune system. And Nivolumab or pembrolizumab are drugs that will break down the PD-L1 expression, the protein on the cell surface, so that the T cells can recognize the tumor. Now, if you had no PD-L1 at all, so that means less than 1% of the cells has this protein, there is no difference if you give the combination of IO treatment or chemo. But if you have any expression, you see that once again, the immunotherapy outperforms the chemotherapy. So it might be a biomarker, because we would like to find the patients who are going to respond, but also the patients who are not going to respond to our immunotreatment, because you have to keep a closer watch on these patients, and also to decide whether you're going to do something else. And with something else, I mean combination treatments, which we are now looking into. It's a waste of time and also frustration if you're going to give for 1 or 2 years a treatment that might not be effective. So how did it do with response rates? And that is, does the tumor shrink good enough? And that was about the same. Chemotherapy was a little bit better, but there were in the immunotherapy arm, there were 2 patients in whom the 2% of the patients, that's about 6 patients in total, where the tumor totally disappeared. And this graph here is the duration of response. That means that if you have a response, so if you're in one of these groups, the duration of this response in months is much higher when you have EP and Nivo versus chemotherapy. The response does not last so long. But it must be fair to say that after 6 courses of chemotherapy, that's 18 weeks, you stop the treatment. So that implies that if you're not going to give anything, the chances that the disease will grow is there. While in 2 years, you will have still some kind of effect. That's one of the comments we have on this kind of graph. Now, how did it work in such a large group of patients? The EP and the Nivo in 300 patients who were analyzed for toxicity, there was 15% grade 3 to 4. And that means that these patients really had to have some medical intervention, while it was only 6% in the chemotherapy arm. But one must also take into account that if you give a treatment for 2 years, it's quite different from something that you give for 16 or 18 weeks. So all the physicians involved felt that it was very good manageable. and the number of patients who died was very small. So we have discussed now in the first-line treatment the 743 study, but there are also others like the BEAT-MESO or the pembro chemotherapy, the 1227 trial, or the DREAMER trial. And these are the new ones that we are going to look at. DREAM and PRE-0505 were the phase 2R studies, so the simple one-arm studies, where they looked at durvalumab plus chemotherapy. So now you're combining chemotherapy, which has a direct cell kill on all kinds of cells, and also hope that your immune therapy will maintain the effect. And this led to quite some interesting data and has led to the DREAMER study, phase 3, and the PRE-0506 study. And this is something that we are now involved in. Here you see, for instance, the overall survival of 54 patients who had the chemotherapy met durvalumab. And you see that after 12 months, which of course is not 24 months, but there was still a lot of patients who had a good response. So this is something that is probably going to be one of the new futures. And here it is more in detail. So the menu for 2021 is first-line immunotherapy or the standard of care. So if you have a condition that does not allow you to have immunotherapy, like severe rheumatoid arthritis or ulcerative colon disease or some other autoimmune disease, then you really must not start on immune therapy treatment, because it really can make your life very difficult. But it's a better menu, and the menu is going to be expanded. So coming back, I think that with the data I showed you, that combination of two drugs, immunotherapy drugs, that is for me now the standard of care, unless there's a reason why you cannot give it for all histologies. We are going to see in the near future, in the coming 2-3 years, what is going to happen with chemotherapy and immunotherapy, because it has been shown in lung cancer that this is a promising combination. And it might take out a few of the patients that we now fail to see, who might have a bit larger tumors and do not respond so easily to immunotherapy. We know that in Japan, the second line, there is a registered drug. And of course, I already said that Nivolumab is better than best supportive care. And I would like to end with one of my favorite UK actors. I hope I did not take too much of your time. Thank you.
Thank you so much, Professor Baas. Thank you so much for that, especially with finishing with Mr. Bean, who is a favourite in the UK. So that was a wonderful, comprehensive walkthrough immunotherapy and combination immunotherapy. And we've had a question come in from Dennis Whitaker, who has put into the chat group that he recently started second line Nivolumab. So we currently have access to Nivolumab due to the COVID pandemic, because it was thought to be less immunosuppressing, and so patients could perhaps access it and be treated with it without the difficulties we have with chemotherapy. So we currently have temporary access to Nivolumab in the second line, and you pointed out there that it is available in Japan. It's been approved. So Dennis was asking for you to just clarify, when you talk about survival in a clinical trial, when does the clock start ticking? Is it on completion of treatment? Is it at the start of treatment? Is it at diagnosis? When does the clock start ticking for your statistics on survival?
Yeah, thank you for this very important question. So if you do it correctly, survival starts at the time you start your treatment. And you must be very clear in this because there are quite a few number of biases. One of them is called immortality bias. It's a bit going too far to explain it all, but suppose you are going to do a study with surgery involved, and you only select the patients who are going to be candidates for the surgery, and you give them first, let's say, immunotherapy. If you start them by the time they get immunotherapy, you will always select out only these patients that will have such a response that they're fit for surgery. The other ones will drop out. And that would be, well, cheating a little bit. So if you have a randomized study, you start, or a single arm study, you start at your most important treatment.
Lovely. And another comment, really, well, a question, I guess. You spoke about clinical trials that have the need for a repeat biopsy built into them so that you can monitor the evolution of the tumor or through the clinical trial. And you know, as somebody involved in supporting patients to look at clinical trial opportunities, you know, I can tell you that the thought of another biopsy is often very off-putting. Is this essential, and are there other ways that we could be capturing that information? Are there new ways just around the corner that will negate the need for a further biopsy?
Yeah, okay. I understand it, and it's always takes some time to discuss this with the patient. So there you have different types of studies, and some of these studies will not help you forward if you do not have any clue what you're doing in the tumor, because most of you all know that evaluating a treatment with mesothelioma can be very difficult. There can be scarring, there can be adhesions, fluid will obscure the view for the doctor and the patient to see what is really happening. So therefore, we discussed with the patients that you could have this treatment, but we had to start with a biopsy because you also need, of course, a firm diagnosis. And secondly, if a second biopsy was not possible or refused by the patient, of course, we don't do it. But we also offered them, for instance, with CT scan or ultrasound, a needle biopsy. Because you want to progress, you want to do research that will also help others. And it's very good that these drugs are now available. I don't know, by the way, do you have ipilimumab already in first line in the UK?
No, so we had compassionate access to it briefly, but it is currently it was reviewed by the National Institute of Clinical Excellence recently, and we're waiting, and we're waiting for their decision. So we should have a decision from them over the next week or so about whether or not it's going to be approved in the first line setting. So no, we have some patients on it currently who were started on it through the compassionate use program. Yeah. And for patients, sorry, apologies about that. I didn't stop my phone. For patients that have a civil compensation claim, then the lawyers have been really good at securing the money for to cover the cost for those patients that have a civil claim. So some patients can have it privately because it's built into the cost of their compensation claim. So we're just waiting really to hear whether or not we'll get the approval through the NHS.
Yeah, it's such a shame that these drugs are so immensely expensive, and that it's a burden for the whole system. At this moment, we also have a compassionate use program for patients with mesothelioma, for ipilimumab, but they also have it now, let's say, cornered. I don't know if it's translated correctly, but because they are negotiating the price, and that is always a bit of secrecy like because the company would like to make a lot of money, and we would like to save some money, but also save lives. And then you can spend your pound or euro only once.
Yeah, exactly. There are another question has come in about if you have had second line single agent nivolumab and that stops working either after 6 months or if you go the full 2 years, is there an option to have single agent ipilimumab, bearing in mind, you know, what you said about the combination? So is that an option? This I think it's a patient that has asked that question.
Yeah. I think at this moment, ipilimumab alone is not a way forward. For this particular case at this moment, because it's a field in motion, is that you would have a combination of, let's say, chemotherapy with one of these new different immune checkpoint inhibitors. So we are always trying to get our hands on new drugs, anti-TIGIT, anti-LAG-3, and combine it. So it's difficult. If you ask me now, is there a study open in my institution? I say no, not for these, but we tend to give, for instance, then gemcitabine, because it will maintain quality of life in the most highest number of patients, and it will also control the tumor to some extent. But it's a difficult situation. You have to discuss this with your physician.
Yeah, so we have similar dilemma to what you've described, really. So we tend to use single agent nivolumab. We may re-challenge with chemotherapy. We have got the MIST platform open, and we've got 2 trials open in MIST currently. So I think we would advise exactly the same as you. Talk to your clinical team. And that question came in from Brian as well. So I just wanted to point out that Brian sent that question in. There's been no more questions come in, and we're out of time. I guess the only thing I would want to finish with is to make a plea, really, that I think we've become a far more digital world over the last 18 months, but we already were before. And I think the mesothelioma community has been global. Patients and advocacy groups such as Meso UK, but patients have been very active, talking to one another. And there is nothing worse than hearing about opportunities in another country that don't come to your country. And so, you know, it's just a plea, really, that, you know, I mean, I know the Netherlands is second to the UK in terms of your incidence of mesothelioma. And, you know, we thank God for people like you, Paul, who have dedicated so much of your professional life to this disease, because you really have pushed the boundaries and opened up opportunities for treatment. But it's just a plea, really, on behalf of patients to always look at the UK. You know, we are an extremely tight-knit, active community, clinicians, scientists, patients, and their families, and we really do recruit really quickly. And there's, you know, having meso is bad enough, and I'm sure I don't need to tell you that, but to actually find out you're missing out on an opportunity because you're in the wrong country just kind of really makes it much harder. So just a plea, really, that if you are developing any clinical trials, please do contact Meso UK, and we can, you know, look at areas in the country that haven't got a lot going on, and really help, because, you know, the quicker we get these trials recruited to, the quicker we can, you know, continue to unlock the doors to better treatment. So just a plea, but overall, a huge thank you for today. And for all that you do for this disease, because you know, patients are and their families and clinical teams, we are tremendously grateful. I don't know what we would do if we didn't have people like you and Dean and Sanjay and Anna who haven't shown this disease so much interest. So so thank you very, very much. Well,
I can only echo you. I think collaboration is really the way forward, and I do have good contacts with Dean and Sanjay, and I regret that we're only doing this on a webinar, because the real interaction with the people involved, the supporting people, the patients, the doctors, the nurses, like you, what you have done, it's so immensely important. Yeah.
Yeah, I couldn't agree more. Well,
for
hopefully
listening, and I hope you might remember my presentation and have some value in it.
we certainly will. Thank you very much. Take care.
Okay.
Thank you, Professor
Bye-bye.
Baas. Bye-bye.